Bispecific antibody constructs are an emerging field in haematology, oncology, and infectious disease. The lead compound in this new technology is blinatumomab, or the BiTE technology. BiTE means bispecific T-cell engaging antibody construct. And it's a platform technology because you can use a respective target. For example, with blinatumomab, it is CD19 that is expressed on B-cell malignancies, including also ALL. And this has now been so successful that this kind of approach has led the EMA to actually have a positive view in a registration trial of blinatumomab. So it's available now in several European countries and also in the United States, Canada, and Australia. But this is only just the first product that has made it all the way. So on the platform technology, using the BiTE platform technology, obviously there are clinical trials being performed now in other malignancies, including AML, multiple myeloma, by instead of targeting CD19 on the cell surface of the cancer cells, targeting, for example, CD33 for AML or BCMA on multiple myeloma. So then obviously the blinatumomab is actually a very small compound. It just takes out the VL and the VH region of the respective antibodies. And it's an effusion protein of, on the one hand, the VL region recognizing CD3 and VLVH region recognizing CD19. And it's just this very small linker of about 8 amino acids, so it just gives it a lot of flexibility in that contract. So it's easy to envision that you can have different formats. So, for example, a format that would include 2 binding agents instead of just having one VH, one VL region targeting CD90, could be 2 VH and VL regions. And also on the CD3 side, it could be a format where you envision having a complete antibody, sort of the normal Y shape, when the one arm it is attacking the cancerous cell and bringing in the T cell. So all these different constructs are now being developed for mainly B-cell malignancies, because obviously the field is most advanced in that context, and now also in clinical trials. But they have shown in preclinical models in mice and also in monkey to be quite able to deplete B cells very quickly within hours after giving the antibody constructs in this situation, and also resulting in proliferation of T cells as they engage then with the B cells in the monkey. So that is saying that using these different antibody constructs, it also has different pharmacological differences in terms of PK in those animals. So the blinatumomab, for example, is a very small, or the BiTE platform is a very small molecule. So, and with a very short half-life of about 2 hours, it gets renally excreted. And the way it is applied now, it is by continuous infusion to the patient. These other constructs, all the way up to a complete full-length bispecific with the IgG format, will have completely different PK in the humans, in the human trials. Hence, the way how it's applied, it's more not in any continuous infusion, more than a 4-hour infusion, 3-hour infusion, more like a traditional way how we apply antibodies to our patients. So that means that the handling of these bispecifics can be very different, and is ongoing work in progress to understand in patients how can stable PKs be established with these different formats, different to blin, which is a continuous infusion in that context. So that is one level of complexity. The second level is that the VL, VH regions, which are the basis for all these bispecifics, may differ quite considerably in their on and off rate of their targets. For blinatumomab, for example, the CD3 proportion of the construct has intermediate affinity. So it doesn't stick very well to the T cells. So what happens, the blin first goes to the B cell, and then the T cell, which sort of prowls around, will then be sucked in that situation. Some of the other constructs is just the opposite. The affinity towards the CD3 is much higher. So the T cells get saturated with it and are more or less carrying with them the bispecific stuck on the cell surface and then engage with the B cell that they might find. So to which degree that is going to have an impact on the efficacy of the drug and what kind of toxicity is to be expected is completely unknown at this stage. And the next level is there are also some constructs which, instead of using CD3 or T cells as their effector mechanisms, they use NK cells. So there's one construct that, for example, uses CD16A as their binding domain, which is expressed on NK cells. And our clinical trials already have been performed with that, demonstrating in Hodgkin's lymphoma that can be active, and it's now in a phase 2 trial. So using different effector cells in that context. So I think it's a very interesting field at the moment to understand on the level of all these different levels, which construct or which platform technology might be most suited to treat hematological malignancies or overall cancer. I think there might be a big difference between targeting lymphoid malignancies, because lymphoid malignancies do sit in the lymph node, in the bone marrow, natural spaces where T cells and NK cells sort of travel through on a very high level, whereas solid tumors, there's definitely less T cells going into that tissue. So, and it's a very interesting question, how that will have an impact on the efficacy of these drugs down the road in that context. It could well be that we are ending up that this is maybe a suitable drug platform for hematological malignancies, but not for oncology in that context. Yes, I think checkpoint inhibitors, or the whole family of checkpoint inhibitors, and it's not just anti-PD-1, but it could be also APRIL and might be very interesting to explore if inbuilt resistance mechanisms can be overcome by adding anti-PD-1. And it's quite conceivable, because if a T cell gets activated, it starts producing cytokines. Some of these cytokines, like TNF and gamma interferon, do induce, for example, PD-L1 expression on cancerous cells. So hence, if you could block that, you maybe still overcome inbuilt resistance mechanisms, and perhaps the bispecific therapy might be even more effective in that context. I'm aware of one clinical trial, actually, a moment or two, that are going to look into that direction in B-cell malignancies. So it's going to be very interesting to see what's going to happen down the road.